Madam, we are live now.
Yeah.
So, good evening, doctors and all the participants. Ishmoon on behalf of Shield Healthcare, welcome you all in today's session. And obviously, it's a very special episode on National Safe Motherhood Day. And the topic of this session is management of postpartum hemorrhage. So it's our pleasure to introduce today's speaker, Dr. Shyamstuti Patnaik, Madam. Madam did her MBBS, MS OBG, and she did her fellow in reproductive medicine, fellow in minimal access surgery, and fellow in fetal medicine. And she is the member of many international and national societies, including ASRM, ASHRE, AGL, FOXY, and many more. Apart from that, in terms of academic activities, Madam attended many national and international conferences and presented her findings. And obviously, it is including AHL 2019. And she is the winner of Best Paper CSD on Prize in EICOG 2022 in Indore. And Madam is the obstetrician, consultant obstetrician, gynecologist, laparoscopy surgeon, and infertility specialist at Shanti Memorial Hospital, Rourkela, Odisha. As you all know, this is not only is a pioneer IVF center of only Odisha, rather it is a pioneer institute in the entire eastern region of India. So with this short introduction, I request Madam to take over the session, and meanwhile, I request all the participants for your active participation. And please drop your queries on the chat box of the Seed Connect page. So once the talk will be over, we shall have a short chat with Madam on this topic. So thank you very much, Madam, for your valuable time to discuss this very important topic in this today's special day. And over to you, ma'am, for further proceedings. Thank you very much.
Thank you, Suman, and thank you, Shield, for this again one wonderful opportunity to speak on another wonderful topic on a beautiful day, which is the National Safe Motherhood Day. And with the pledge that we all ensure safe motherhood to all our patients, I think this topic, that is PPH, is of grave importance to the clinician as well as the patients. So without wasting much time, let's go to the topic. And as the name itself is depicting, that we are here to work for safe motherhood and do something which would help our patients and help us even. Is it visible? Is the screen full screen fine?
Yes, madam.
Okay. So before starting PPH, I think it's a nightmare for all the doctors, all the gynecologists, even if the general practitioners in periphery and other places where delivery and cesareans are taking place, or uh, any institute for that matter, because PPH is something which involves the life of a mother. And when she's given birth, that period of time, it is extremely sad and unacceptable that a mother is going to suffer. Any kind of maternal morbidity or mortality is a shock to the society, to the newly parents or newly formed parents, newly formed family, the relatives, the doctor, the medical fraternity, and everyone. I think PPH is a very, very serious and sensitive topic. And we know that very recently, junior, very young gynecologist losing her life because the world claimed that she could not manage a PPH, or could not make the patient party understand that what happens in PPH and what are the things that we can do and what are the things that we cannot do. So I think this is something that, at least from our side as clinicians, as gynecologists, we should be 100% sure about the things that we can give to the patient, cater to the patient, and when to refer and what to do at the correct point of time, because time is something which is very, very crucial when we encounter PPH. So before going to the scientific part of it, I would like to tell each and every gynecologist coming here to listen to a topic of PPH. The first thing that we all have to be when we encounter PPH is be calm and stay calm, keep calm. also have all the faith in our Almighty that we do not lose a patient to such a thing, because anything can happen in a few seconds, even if we are correct. Our decision-making capability should not be altered due to the anxiety, the stress, and the time running away when we encounter PPH, because we are always anxious enough because we may lose a mother, a newly born child may lose a mother, or whatever maternal morbidity is associated with it. So all we have to know is that we need to know what best we can do for the patient, and what are the conditions in which we should not manage such a patient and refer when. Prenatal, antenatal, postnatal, all the scenarios and history has to be checked, and then we should take a decision. Because it is really, really important for all the new gynecologists, PPH should not be taken very lightly. And there are various things that we should do to prevent a PPH, because I have seen many young people. I'm also in the younger generation and all that. Whatever I'm seeing, there is a very strange attitude towards a delivery. I think a normal vaginal delivery can create many complications, can have various other scenarios, various sequelae that can happen, because it's not a small thing. It's not about doing a big surgery or a big this thing. Delivery and cesarean section after a period of time becomes very I find clinicians, whether young, old, middle aged, whatever, becoming very careless about the fact, oh, it's a delivery, oh, it's a cesarean. I think that's not how the attitude should be. I think that is where we can prevent most of the PPH, is by being vigilant during just managing a normal vaginal delivery, even if it's not instrumental, or even a cesarean section, no matter how experienced and how uh, uh, you know capable, or we are of managing that situation. I think anything can turn out at any time, so we need to be very careful, scientifically, emotionally, and medico legally also. So going ahead with the medical management of PPH, because PPH is a huge topic and it has various ways of managing. So coming to the medical management, before that, we would like to know what is the definition of a postpartum hemorrhage. When do we know it is an alarm that is ringing on our head? PPH, also called postpartum hemorrhage, is when a woman has heavy bleeding after giving birth. In common terms, if you know this, it's serious but a rare condition. It usually happens within 24 hours of giving birth. It can happen up to 12 weeks post delivery. About 1 to 5 in 100 women who have a baby, 1 to 5%, you can say, may experience postpartum hemorrhage. Immediate postpartum hemorrhage within 24 hours of birth. Late postpartum hemorrhage, it's like after 24 hours of birth. So more than 500 ml, 3.5 to 30% of the cases we see that we call it a PPH. When do we term it as a severe PPH? When it's more than 1 liter or 1000 ml. Roughly, these are the estimates. We do not do it in every case, but statistically, cases and case studies have chalked out these kind of average parameters. Is 1.5 to 5% may witness severe PPH. That's more than 1 liter of blood loss. Coming to this part, what is the history of maternal mortality in India? We all know that MMR is a very big concern for the government of the country. PPH is one of the major causes of MMR. It's one of many countries who record a high amount of pregnancy-related deaths of women each year. They die as a result of the complications during and following pregnancy, childbirth, or abortion, even though most complications are easily preventable or treatable. So that's what we are here. Prevention is better than cure. So we need to look forward more towards preventing PPH than curing PPH. So over the years, in the last, 2010 to 16, we can say there is an annual decline in MMR by 3.5%, annual increase in skilled birth attendance because of the various programs by the government. And kudos to the government also. 4.7% increase, 77% decline in MMR up till 2016. So this is quite a big thing. Since 1990, it has been this level, 556 mmR. It has come down to 122, which is a big number. And I think all the private practitioners, along with the government officials, should be given a wonderful accolade or applause for doing it. And we should still continue doing it. What is the reason to focus? Why are we concerned about it? Hemorrhage is the largest Direct cause of maternal death. It is mostly unpredictable. Most PPH is caused by uterine atony. So atonic uterus is what we have to look for in most of the cases. Evidence-based, feasible, low-cost interventions do exist, and we have to implement them first. Active management of the third stage of labor can prevent 60% of PPH. It occurs in 5 to 15% of the patients after delivery. Primary PPH is usually considered as a disorder of one or more of the four processes: uterine atony, retained clots or placental debris, genital lesions, and disorders of the coagulation. So the acronym, which is the 4 T's, tone, tissue, trauma, and thrombin. That's how we remember the various etiology and the causes of it. The name itself justifies it. Tone means when the uterus loses a tone, that is atonic. Tissue, various tissue and collagen disorders. Trauma, any form of injury. Thrombin, that is when we have the blood coagulatory defects. What is the classification again, as we see, depending upon the blood loss, acute blood loss? So the percentage lost, we can see here that this is a Benedetti's classification of hemorrhage. One of the main problems is underestimation of the blood loss. So we do not know how to estimate it. We do not always calculate the MOPS, the everything, because the blood flows away. And also roughly, I think by experience, by various other parameters, we can know how much blood loss is there. So hemorrhage class 1, 2, 3, 4, according to this classification, we can very well see 900 is class 1, 1200 to 1500 2, 1800 to 2100 and 3, and 2400 above in 4. So what are the various risk factors? Where do we have to be very, very vigilant and careful when we are dealing with the childbirth, in this case, antenatally and postnatally? Retained placenta, failure to progress to the second stage, placenta accreta, various lacerations that can be formed during delivery, instrumental delivery, newborn, large for gestational age, another big reason for big babies, hypertensive disorders, induction of the labor itself. We have to be very, very cautious, because again, there is various dystonia of the uterus, where the tone of the uterus goes haywire at times. So induction of labor is one big cause. Just simply induction is also a big cause. Augmentation of labor with oxytocin. So antenatally, what do we have to see? The past history of hemorrhage, the risk in first, second, and third pregnancy. If we have PPH in previous pregnancies, what is the risk in the next pregnancy? First, we can see 5.8%, and second, we have it up to 15%, and third, again, up to 22%. So we have to be very, very careful with the history. Abruptio placentae or placenta previa, as we all know. Multiple pregnancies, again, 3.3%, mostly after twins or triplets. We do find atonic PPH, which is a very big reason for PPH. Macrosomia already discussed, big babies, large for gestational babies. Hypertension in pregnancy, any pre-eclamptic state, eclampsia or HELP syndrome, where we know that it is a milieu of many things, elevated liver enzymes, low platelet count being a very, very big etiological factor here. Antepartum, if we have chorioamnionitis, around 2.7%, which is not a small sector. Polyhydramnios or multiparity, fetal death, anemia, uterine myoma, or manual removal of placenta. These are the few risk factors or conditions where we need to be vigilant about PPH, and we can encounter PPH. Intrapartum, operative and instrumental. So the various risk factors that I've already spoken about, they can be divided according to the timeline, like before delivery, during delivery, and post-delivery. Prolonged labor, again, precipitate labor, or induction or augmentation. Intrapartum again also includes chorioamnionitis, internal podalic version, extraction of the second twin, shoulder dystocia, general anesthesia with inhaled agents, or any acquired form of coagulopathies, like in case of HELP or DIC. Postpartum, what are the risk factors that we can have? Any lacerations or episiotomy wound, retained placenta, very, very big chunk. So we need to, if we can, always put in a hand and remove all the clots and check for the cotyledons when the placenta has come out, which has to be a routine practice for all the people delivering children, to check for the placenta structure and the cotyledons, and complete removal of placenta has been done or not. Even a few membranes left over also lead to a lot of PPH. Placental abnormalities, uterine inversion or rupture, acquired coagulopathies, as in case of DIC, which also IUD followed by DIC is a very, very big thing, or a sequelae that we usually see for PPH. So diagnosis, how do we know? As we said, the underestimation of blood loss is a very strange kind of a thing when we are doing a delivery and this and that cesarean. Sometimes when there's bleeding, our focus is on doing it. So we do not estimate the amount of blood loss that has already happened, seeing the number of MOPS or this and that. So we need to side by side keep a track of the amount of blood loss that has happened. So quantitative methods are visual assessment. As I said, direct collection of the blood into the bedpan or plastic bags, which is clinically not that very feasible. Gravimetric method is also there. Changes in the hematocrit and hemoglobin, of course, post-operative or post-delivery, if we check, we can know about it. And the other things are by checking the plasma volume or the tagged erythrocytes, which are not usually thing, but visual assessment is a very big thing that we have to be vigilant about. The risk of placenta previa was 0.26 with an unscarred uterus and increased almost linearly with the number of prior cesarean sections. Being the era of the cesarean sections, due to patient's comfort, also we know that if the C-sections are increasing, the PPA chances are also increasing. With each C-section, we have more probability of a PPH happening. So it is around 10% in a patient with 4 or more cesareans. With a placenta previa or one previous cesarean section, the risk of the placenta accreta was 24%. This risk can continue to increase to 67%, 2 or 3, with a placenta previa and 4 or more cesarean sections. So we can see in accreta, previa, and various other placental dysmorphologies and all that, how it has been doubled and tripled the risk for PPH. The physiological adaptations during pregnancy, the maternal blood volume expands by 40 to 50% during pregnancy. This is a physiological change that we all know. The blood flow to the gravid uterus at term is 650 ml per minute. Large amounts of blood can be lost rapidly from the placental blood in absence of the uterine tone. So we know that the vasculature is increased. So it is the uterine musculature and the tone which is going to contract the vessels. That is the reason why PPH doesn't occur. When that normal physiological thing, the contraction of the uterine vasculature does not happen, then of course the blood that we have, the extra blood that is supplied to the uterus is definitely going to come out and the lady is going to lose from her main pool. So the living ligature, as we know, that's a term given, we have always been taught about it. The myometrial fibers in the middle layer run in crisscross manner and have double curvature. As we know that they say God is the biggest scientist, and the way our human body is even formed, from that we can know that how intelligent or how advanced even our creator is, which even we are adopting, or we are copying, the various mechanisms in our physiological system to prevent various diseases. So we put a ligature. So this is why we term it as a living ligature already given by God. So the contraction of these fibers occludes large, that is spiral arterioles, blood vessels that run between them. So as we have already discussed about the 4 T's, tone, tissue, trauma, and thrombin, uterine atony constitutes 70%. Again, full bladder, it has to be a routine protocol to empty the bladder post-delivery, and always catheterize during a C-section, a very normal thing. Tissue, there any retained tissues, placental or whatever, or clots. Trauma, again, uterine, cervical or vaginal lacerations and other things. And thrombin coagulopathies, pre-existing or any acquired coagulopathy. So the golden hour, again, time is important. Time by which resuscitation must be initiated to ensure better survival, because if medical therapy using 3 or 4 uterotonics has not worked within 1 hour, there is no logical reason to think they will work in the next hour. So it is the first few minutes followed by half an hour and followed by the next 30 minutes. That's the first 1 hour post-delivery, the most important thing. And if we do the correct thing, we strike the iron when it's hot, we don't have to suffer. So the rule of 30, what is it? Patient has probably lost more than 30% of the blood volume if the fall in the systolic BP is by 30 mm of mercury, heart rate rises by 30 beats per minute, respiratory rate rises to more than 30 per minute, hemoglobin or hematocrit drops by 30%, urine output is less than 30 ml per hour. It's diagnosed with moderate to severe shock. The lethal triad, again, we have to be very careful. We have to, of course, see when is the person getting into shock, but what is the lethal triad that happens here? Hypothermia, acidosis, and coagulopathy. We need to have it in our mind and be very careful. What is the prevention of PPH? We have to identify the predisposing factors. We have to treat anemia and educate patients regarding the PPH. High risk patients to be managed in tertiary care. IV access, very, very important to first have a large bore IV cannula being installed. Arrange the blood if assist at risk. As such, invariably, if you're finding any risk factors, any anemia, hypertension, and other reasons, previous C-sections and other things that we have, or previous history of PPH, we should have 1 or 2 units of blood in our hand before going for the delivery. Very, very important to arrange the blood. And active management of third stage of labor. Very, very important. So active management of the third stage of labor, what are the various components in it? Delayed cord clamping, not only from the pediatric or the neonatal point of view, for us also it definitely is of help, 1 to 3 minutes. Delay of cord clamping, controlled cord traction, that is a skill that we have to develop and teach, that how much traction we are going to give, how we are going to put the other hand, and the coordinated use of both the hands for controlled cord traction has to be taught to all the people or all the birth attendants who are being trained nowadays. Uterine massage and when to do. Bimanual compression, balloon tamponade, also a beautiful procedure. Just by a Foley's catheter, the balloon being inflated, we can definitely take care of PPH due to the compression of the spiral arterioles or the vessels due to the pressure formed by the balloon. Various compression sutures, which does not come in the medical management, but we need to know when to put them and how to put them. That's also another art and skill that has to be, because many a times you've seen with those compression sutures, PPH does come down. And uterine artery embolization are other procedures. Systematic devascularization is one more than hysterectomy. But we do find that we have to take a decision of hysterectomy if we are not able to hold it with compression sutures or other things, because the woman should not lose her life. That is where you have to take a call, how many minutes you can wait before the lady goes into shock and loses her life, or due to any other lethal triad that I've spoken about, and how much time can you wait. So that is how where it has to be taken. We cannot just use this method and take our own sweet time to do all these. So that's very, very important. We have to check for the golden hour. And again, active management, this is a schematic diagram. We give oxytocin within 1 minute of the birth. We deliver the placenta by controlled cord traction and counter pressure on the uterus. We massage the uterus through the abdomen after delivery of the placenta. Various other uterotonics and others can be given, which we are going to discuss. Further, what are the things? But oxytocin being a very big thing, IV and IM, that is what the first thing that we give. So initial treatment of PPH includes early recognition followed by prompt attention to the resuscitation and a simultaneous search for the cause of the bleeding. Once PPH has been identified, management involves 4 components, that is communication, resuscitation, arresting the bleeding, monitoring, and investigation. Very, very important. So we need to counsel the patient party and everything and take consent for various procedures that we can do. And we have to resuscitate knowing the condition of the patient. We have to ensure hemostasis. We have to follow by that, even if it's controlled or whatever, we have to monitor and investigate a few other things to know the present status and how we have to be prepared for the next few hours or the next few days. So the joint statement, as we can see, given by ICM or FIGO, an algorithm has been suggested for the management of PPH. If we remember this, I think we would have all of it in our mind. That is hemostasis. H being first ask for help. If you're not well equipped, if you have no idea about what's happening, we need to take the help of seniors. We need to have our intensivist and other things at hand. We need to have a blood bank at hand. We need to have various things at hand. So ask for help to no matter whoever you can at that point of time. We have to assess the vitals and the blood loss and resuscitate. So very, very important is the estimation. Establish the etiology or the causative factor so that we can catch it and hold it. We have to check for the ecbolics like signometrin, ergometrin, bolus intercinon, and other things, whether we have it with us or not. And of course, blood. Very, very important. We need to procedure or going for anything, we need to have blood in our hand with cross-matching and other necessary things done. Massaging of the uterus for M. O, we have oxytocin infusion, prostaglandins, IV, rectal, IM, or intramyometrial prostrodin or whatever we can give. So we can try out everything, but everything has to be fast enough within a few minutes, and we have to ensure that hemostasis is maintained. Specific surgical things, what we have for S, we have shift to the operating room, exclude retained products in trauma, bimanual compression, anti-shock garment if transfer required. For T, we have tissue and trauma to be excluded, proceed for the tamponade balloon or uterine packing. So it's more of the physical and the mechanical pressure here. So for A, we have the compression stitches, we apply them. For S, we have systematic pelvic devascularization, like we catch the uterine arteries, we catch the ovarian arteries, the quadruple, internal iliac, and other things, but we need a skill and we need to routinely do such procedures to do it. So then we have the intervention radiologist or the uterine artery embolization if appropriate, but I don't know how far we have the facility of it at every centers and how fast we can do it. Subtotal or total abdominal hysterectomy can be done and taken a call when to do. Multidisciplinary approach, again, as I said, we need to call everyone who's possible, who can help us at that very situation, like a senior obstetrician and anesthetist, all the midwives or nursing staff, the theater staff, OT theater staff, I mean, hematologist, the blood bank, the hospital porters, and ICU, of course, an intensivist. Very, very important to be at hand. We have to assess and resuscitate. And one more point I would like to tell here, that even if we do not have this multidisciplinary approach, we are seeing something, without any further delay, we can definitely refer to a higher center without wasting time. So we need to know in which center we are, how much facilities we are having and resources we are having. So referral is very, very important. Timely referral and in a proper way to a proper institute is even more important. So assess and resuscitate, assess the vital signs and estimate the blood loss. Adequate venous access, like a 2 large bore IV cannulas at least should be put from 16 to 18 gauze. You have to draw the blood sample around 20 ml for various investigations, the routine investigations, especially complete blood count, the grouping, cross-matching, coagulation screening for the renal function test and the liver function test, because that would also tell us the etiological causes of the various blood disorders that we can find out. Foley's catheter, of course, monitoring adequate renal perfusion, and also sometimes that simple Foley's can help us to have a balloon tamponade also. Estimation of the blood loss, visual, as I already have told, 30 to 50%, it underestimates it. So we have to always keep something extra and add it extra in our minds. The clinical symptoms, change in the clinical status, may lag behind the blood loss. Not necessarily the pallor and other symptoms would correspond to the blood loss. And PPH bags, of course, to, the clots and others can be weighed at times. So volume replacement, the fluid of choice is crystalloids over the colloids. Crystalloid of choice is the ringer lactate crystalloid, 3 to 5 ml per ml of blood loss to maintain the urine output at more than 30 ml per hour. So our target is to maintain the urine output more than 30 ml per hour. So whatever RL or other crystalloids that we are using, at least 3 to 5 ml per ml of the blood loss. So the estimation of the blood loss has to be done in a proper way, and always maybe an overestimation is better than the underestimation. The loss of 1 liter of blood requires replacement with 4 to 5 liters of crystalloids, that is NS or RL, or colloids until cross-matched blood is available. So we can always resort to that also if at all cross-matched blood is not available. In class 3 or 4 hemorrhage, what is the CEB of the basic life support that we should provide? Circulation, that is circulatory blood volume, must be restored and maintained. Infuse 1 liter crystalloid solution within 15 to 20 minutes. At least 2 to 3 liters of fluid in first hour to be given. So this is the rate at which we have to infuse the crystalloids. Very, very important. How much to give and how long to give. We have to ensure airway. As we know, CAB, the name itself says, if we have it in the back of our mind, the airway is patent or not, because we do not want the patient to get into a circulatory collapse or stop. Breathing, if respiration is not adequate, we involve the anesthesiologist and intensivist. So CAB is what we have to remember. Shock index also we can calculate. That's a heart rate by systolic BP. Normal value is 0.5 to 0.7. Insignificant hemorrhage significant hemorrhage, we have it 0.9 to 1.1. So the change in the shock index is a better correlation and identify acute blood loss. So that is where the importance of shock index comes, and that is how we calculate or have it in our mind. We have to establish the etiology, have ecbolics at hand, and ensure availability of the blood. So for tone, if the tone is the reason, atony or dystonia, start massage and uterotonics. Trauma, we examine under anesthesia for lacerations, tears, and other things, and repair it or put a pressure pack. on it for compression and hemostasis. Tissue being the disorder, whatever is left over, placental tissue or clots and everything can be removed. Thrombin or the coagulopathy disorders, we correct it with various other blood products like fresh frozen plasma if we have low platelet and other things, cryoprecipitate, and other uh, uh, modalities to treat the coagulopathies. Massaging uterus again manually and bimanually. Bimanual is of course always preferred. What is it? Otherwise, when we are having one man hand, our assistant can do a manual compression. That is what the difference. The hands, the same person. We form a fist, place the fist in the anterior fornix and apply pressure against the anterior wall of the uterus. With the other hand, we press deeply onto the abdomen behind the uterus, applying pressure against the posterior wall of the uterus. We maintain the pressure until the bleeding is controlled and uterus contracts while continuing resuscitation. Measures are being taken simultaneously, not only just this. Oxytocin infusion again for management of PPH, oxytocin should be preferred over other uterotonics. If oxytocin is not available or alone is not effective, we can switch over to ergometrin or oxytocin ergometrin fixed dose combination should be offered as a second line of treatment. Like usually we use methergin and other things, but nowadays due to the various complications and side effects, we better avoid methergin. If the above second line treatments are not available or not effective, a prostaglandin should be offered as the third line of treatment. So sometimes many people are skipping, ergometrin after oxytocin and switching over to prostadin and other prostaglandins. Butyl ergometrin require very specific storage conditions as they deteriorate rapidly with exposure to light, heat, and humidity. Side effects are nausea, vomiting, paresthesias, chest pain, tinnitus, headache, and increased BP. It is contraindicated, very, very important in hypertension being the number one, I would say, instead of these, then followed by other things like heart disease, sepsis, migraine, peripheral vascular disease, Raynaud's phenomenon, or any liver or kidney diseases. So that's what in the routine test, we definitely have to check the BP. Our vitals have to be at their hand. We need to have an RFT and LFT also done if you're suspecting any risk factors. So that is why we know that methergin does not have to be given there. Symptometrin, combination of oxytocin and ergometrin, as we said, there's a fixed combination, 5 units plus 1.5, 0.5 mg. It is given IM. No important clinical differences in the effectiveness of symptometrin and oxytocin for the prevention of PPH. Nothing better. It is associated with a higher risk of hypertension or vomiting. In severe PPH, symptometrin did not demonstrate a benefit, rather cause increased side effects such as hypertension and vomiting due to ergot component. So this is something which is not popular or famous because of its side effects. Coming to PGF2 alpha, very preferred nowadays, post cesarean and other things. It is administered in doses of 0.25 mg IM. Contraindication is asthma due to bronchoconstrictive properties of the F class of prostaglandins. Produce nausea, vomiting, diarrhea, and pyrexia. Case report of severe intrapulmonary shunting and hypotension seen. So very, very important. We need to rule out bronchial asthma or any other bronchoconstrictive disorder before giving PGF2 alpha. Otherwise, we can have a nightmare. Cardiac or pulmonary and renal and hepatic diseases are also contraindications. Misoprostol, and a very, very common drug usually at our hands, at our fingertips, and we left and right, we all obstetricians put misoprostol rectally, but vaginally for various causes. So it is a wonder drug for all of us. So synthetic PGE1 analog, orally given, vaginally, rectally, sublingually, oral or the sublingual route, faster onset of action, rectal and vaginal routes, greater bioavailability, and longer duration of action, inexpensive and temperature stable. So plasma concentration peaks in 30 minutes with oral and 1 to 2 hours with vaginal. So it has a prolonged effect. So preferably rectal and vaginal always. Adverse factors, again, dose dependent. We need to see the amount of blood loss, decide weight and everything and check, give a misoprostol, not just simply putting in 3 or 4 tablets, just like that. And not only under doses, also 1 or 2 tablets wherever in cases if we require 3 or 4 tablets, we need to see the dose and adjust the dose depending upon the blood loss and various other factors. So adverse factors, what we can see, nausea, vomiting, diarrhea, chills, shivering, fever. Tranexamic acid, another wonder drug for our obstetricians and gynecologists. It may be offered in the treatment for PPH if bleeding may be partly due to trauma. That is a very strong recommendation by WHO to 2012. There is a consensus view that fibrinolytic inhibitors such as tranexamic acid seldom have a place in the management of obstetric hemorrhage. So it may not be of much help, but definitely it has a role in controlling blood loss. Blood component therapy, massive transfusion protocol. It involves transfusion of more than 10 PRBCs in 24 hours. So 10 more than 10 units in 24 hours. It's a massive transfusion. Ideal ratio of RBC to FFP is 1:1. It can be combined with PRPs if thrombocytopenia in 1:1:1 ratio. So RBC, FFP, and PRP 1:1:1 ratio. That is how we can try it. So this is how the blood component therapy works. What are the various recommendations? Every department needs to have a protocol for the management of this thing with periodic re-evaluation like the life support training. So a place, a unit or a clinic or a institution should have a PPH protocol and should have a drill that what if this happens, what are the drugs at our hand, who are the people to be called, how do you assess it, even if the doctor is not present, a midwife or trained wife, whom to call, when to refer, how to arrange the blood, and how to keep the emergency trolley ready. So a drill, a mock drill has to be done in every institute so that we do not suffer at the golden hour. So cases at risk of this need to give birth at a level 2 or level 3 structure. As we said, if you're not well equipped with less low resource settings, we need to refer as soon as possible. Uncontrollable hemorrhages may necessitate hysterectomy. An expert surgeon needs to be available quickly, 24 hours a day. We activate the multidisciplinary team early in the management of a case at risk. Institutional guidelines for the treatment of hemorrhages with periodic simulation training, skills and drills. So this is how we have to keep ourselves prepared for the right time. I think these are the various basic things that I've spoken about, and people would have got an idea about the various things. We have not discussed about the various surgical procedures, which I've just touched down the few points like the compression sutures or hysterectomy or uterine artery ligation, internal iliac ligation. These are the skills that we have to acquire. But medical management, I think these are the few things that we all give. And as we know that oxytocin is our preferred drug, we give it IM and then IV keeps on going with multiple units one after the other. We do combine it mostly with methergin or a prostrodin depending upon the contraindications. Very, very important: hypertension and asthma. These are the few take-home points that we all know. We have to assess it. We can give our wonder drug misoprost with it also. We rule out all the 4Ts and find out the reason what it is. And the most important thing, not to take PPH carelessly. Once PPH has set in, I think we cannot leave the side of the patient. We have to train our staff, our nursing staff and everyone to be vigilant. And even if God is giving us time every now and then, it's not, we need to have everything at hand. We need to arrange the blood products. And most importantly, coming to the medical legal aspect, we need to speak when we see a risk factor or we see a patient who's going to go for PPH. Not always that we are going to chalk out the patient, oh, this PPH is going to happen. Not necessarily, even if a few risk factors that I've discussed is not there, PPH can happen. But the most important thing is counseling of the patient party. We need to make a patient and patient party sit. I know it's very, very difficult that when a person is going to have a child or maybe a primary or something, and just to tell them that, oh, PPH can happen, she can die, it's very, very difficult to make them understand. But when we have risk factors and other things, we need to counsel them in a way that we need to be prepared for it. We need to have certain things in our hand and go ahead with it. Because nowadays, most of the pregnancies are high-risk pregnancies. So we have to be very careful. We have to save ourselves before saving the patient. So medical legally, we cannot just lose our lives. We have to keep ourselves secure with proper consent and counseling and then go ahead and save another life. So I think I've covered many things about PPH, and I would like to give it to others to go ahead with a few questions or any other discussion if they have.
Thank you very much, madam, for this excellent talk on this very important topic, PPH. Almost you have covered all the parts in brief, although it is a very big topic meanwhile. So, ma'am, if you allow, we can take the questions.
Yeah, sure, please.
So, ma'am, first question is, which patients are more sensitive for PPH issue? Any recommendation or guidelines is there?
Yeah, as I spoke about the risk factors, like the previous history of PPH, very, very important. Anemic ladies, hypertensive ladies. We do, I know we routinely do not do an RFT and LFT, but history is most important thing. And clinical correlation, clinical examination. We see a pallor, we see icterus, we see the history, and that is how we have to make up our mind that yes, this lady may have all the chances to go for PPH. And this is how we have to chalk out our patients, to keep our patients and keep a tag in our mind, okay, high risk. Even the people coming in the government setup, there have been guidelines given in the various Matrujyoti and other programs that when you find these are the things, you need to write high risk. So high risk has to be in our mind when it comes to private practice and other things also. So these are the various factors which I've already mentioned before. Multiple pregnancies, one more. So these are the few big, sections of the causes of PPH that are discussed. Percentage, if you make a pie chart, I think anemia, hypertension, liver disorders, or multiple births, and would take a very big chunk of all this. So these are the few risk factors in previous history of PPH again. So many people cannot share it, but we need to ask you that whether it was there or not, whether she had anemia post first delivery, even if she doesn't give a frank history of PPH, because the patient would not understand, and not necessarily the patient will have an institutional delivery. There are so many home deliveries and other things. So all this history is important. The mode of delivery, whether instrumental delivery was there or not, the number of the cesarean section, first, second, third, fourth, as we have discussed already. So these are the various factors where we know that yes, this lady is a probable candidate for PPH and a nightmare for us.
Yeah, thank you very much, ma'am. And as you have mentioned in this word hemostasis, and in case of this H symbolizes that help means if any problems, ask for help to seniors. But before that, what are the critical parameters to assessing this PPH?
Yes, as we said, first is the visual estimation of the blood loss. Second thing is the vitals of the patient's clinical correlation of the patient. How is the patient doing? The vitals will give a very big indication. A simple BP pulse and this thing temperature would give us a big thing, because in the lethal triad we have our hypothermia, and the shock index we have our systolic BP and heart rate. So just simple four vitals can tell us a lot about the deteriorating condition of our patients. So that is very important, besides the blood loss that we see. And of course, that's what I said. But just these two few things can directly direct you that the patient is not fine. That's all.
Thank you, madam. And last one
And of
thing
course, the
is,
tone of the uterus, very important to put our hand inside the uterus immediately post delivery to clean whatever is left over, the tissue or the clots, and keep our hand on the uterus to see the tone. And a very experienced hand can definitely know with both the hands that how is the tone of the uterus, contracted or not, and of course whether it is clean or not down there, and a pulse speculum to see the tear. Just within a few seconds we can do all of it. With one hand we can check the contractions, with the other we can clean the uterus and put one speculum down and see. I think it's just within a fraction of seconds we can take care of all the T's, even if coagulopathies is dependent upon the blood reports, but the first three T's can be diagnosed there itself.
hello, am I audible, ma'am?
Yeah, tell me.
Yeah, thank you. And the last question is, ma'am, postpartum tachycardia and the chances of PPH. So any observation on that, ma'am?
Yeah, of course. The heart rate is definitely, of course, in shock, we would have a circulatory collapse and this thing. But tachycardia is also, there are various conditions, as we said, underlying conditions can be there, cardiorespiratory conditions can be there. So tachycardia is also very important to tell us regarding the overload on the cardiac side and the blood loss. So we need to monitor it, and we need to rule out other causes, or if at all any adverse reactions from any uterotonics. So that is also very important to see the heart rate.
Thank you very much, ma'am. So thank you very much, ma'am, for this nice session on this very important day, National Safe Motherhood Day. And in future also, we would be very happy to organize such kind of academic session with you, ma'am, in our platform Sheet Connect. So thank you very much and have a good day.
Thank you. Thank you so much for giving me this opportunity again for this wonderful day and wonderful topic. Thank you so much.
Thank you very much, ma'am.